settings, devices. So your noise suppression settings are here.
So there should be a no option.
Good morning, everyone. And for some of you, welcome back, because this will be your second introduction to your working as a doctor. And this is your welcome to foundation training, and this is a collaborative session between your health boards and also the deanery and the foundation team. My name is Lindsay Donaldson. I am the Director for Medical Education within GGC, and I'm here on behalf of the Directors of Medical Education in the West of Scotland, and I will shortly hand you over to Dr. Caroline Whitton, who is the Associate Postgraduate Dean for Foundation in the West. But before I do that, a huge welcome to the first day of you working as a doctor. Some of you have been working for a week, but some of you, this is it. This is your first day. And we also are live streaming this from the college in Glasgow, and as a very short and brief celebration of that, we have the president of the college with a short film to welcome you. Thank you very much indeed.
Good morning, everyone. I'm Jackie Taylor, President of the Royal College of Physicians and Surgeons of Glasgow, and on behalf of the college, I'd like to welcome you to this session on foundation training. This is a really exciting time for you, but I know it can feel a little daunting. So I think it's really important at this stage to remember what you have already achieved in getting here. You are all without doubt capable of being great doctors. I hope that you've enjoyed your sessions in the simulation centre here in the college, and that those simulations have helped to build your confidence. Today, you're going to be hearing from my colleagues from the Deanery, the Health Board, and the BMA. We all have different roles to play, but what we all have in common is that we're interested in you and in making sure that you have the best possible experience during your foundation programme. As a Royal College of Physicians and Surgeons, we will be with you throughout your entire career by providing education and training, professional and personal development, and actually also, most importantly, by being your voice in professional issues. Now, I know you're going to be hearing some top tips from today's speakers, so I've been reflecting on what I think my top 3 are. There are many, but my top 3, I think, are, first of all, to be a really good doctor, you have to be self-aware. And it's very important that to look after others, you also look after your own well-being and health. Second, look after your whole team. Help each other out. There's no doubt that peer support is one of the crucial things that will really help you and will enhance your experience. And third, never underestimate the power of kindness and compassion to your patients and to your colleagues. I hope that you have a very, very enjoyable session this morning, and I look forward to welcoming you to our college.
Thank you very much indeed. The next session is being hosted by Dr. Caroline Whitton, your Associate Postgraduate Dean for Foundation. Thanks very much, Caroline.
Good morning, everybody. So my name is Caroline Whitton. I'm the Associate Postgraduate Dean here in the West of Scotland. I'm also a consultant geriatrician at the Queen Elizabeth in GGC. And I'm here to welcome you to your first day of being a doctor too. We have an audience here and they smile at me every year when I say this, but this year I have been a doctor for 30 years. And I'm here to tell you, I can't believe it. They're looking not really in disbelief. They can believe it looking at me, frankly. But the point is this. 30 years has gone just like that. 30 years ago, I couldn't believe it was all ahead of me. And today, I cannot believe I blinked and it's all behind me. So my first piece of advice to you is enjoy, because it's a fantastic, fantastic career. And it will be over before you know it. So you're joining this. Thank you for being part of the NHS. And we still remain one of the best loved institutions in the UK, and it's an honour and a pleasure to be part of it. You've already seen the programme for today. It's part health board based, part nest based, and it's to try and introduce you and welcome you into foundation training. So, welcome to foundation training in the west of Scotland. And from this day onwards, you never ever have to go onto a ward and introduce yourself to a patient as just the medical student. You're no longer just anything. So I want you to drop the just, and I want you to say confidently, hello, I am your doctor, and enjoy that moment. So in the west of Scotland, we have a lot of trainees. We've got this year 441 FY1 trainees, and I'm hoping that I am speaking to 441 trainees right now. We have 32 programmes in the west of Scotland, and within those we have between 15 and 18 rotations. Some of them are empty at the minute because next year we're expanding again and we're going up to 465 trainees. Most of our programmes are split between GGC, because that's our largest health board, and the peripheral health boards. Some are located in one of the peripheral health boards, others are located in GGC. And we have one academic programme which is based in university-linked posts. And you'll know your Scotland map. I'm assuming some of you are from Scotland, some of you are not, but this is what it looks like. And we in the West have more than half of all foundation trainees. And we have 6 health boards in the west of Scotland. So, what is foundation training? What's the point of it? Well, it's an essential part of your junior doctor training. And it takes you as novices and it trains you spirally with gradually increasing supervised independence to the point that you're ready to enter specialty training. And its purpose is to provide you with thorough and extensive training focusing on the generic capabilities which are going to be the basis of your professional lives as doctors. So it's to give you literally the foundation on which you're going to build the rest of your medical careers. So the purpose is to help you transition from being medical students to being independent professional practitioners. As you enter FY1, you'll have your provisional registration. As you exit FY1 successfully, you will gain your full registration and then enter FY2. And then when you complete FY2, you'll be able to move on to specialty training. So the purpose of foundation training is to aid you in your ongoing learning, and most importantly, actually, is to guard patient safety, because fundamentally, that's what we're all about. We're here to provide safe patient care. And in foundation training, we do that by ensuring that you are competent, capable, and caring doctors. You may have heard of the 4 stages of competence, which was an idea put forward in the 1970s. The first stage is unconscious incompetence, and that's what you and we all were when we entered medical school, i.e. we knew nothing and we didn't even know what there was to know. You go through medical school and you attain the dizzy heights of conscious incompetence. That's you as you start foundation, and me when I started my house jobs. And that's when you begin your life as a doctor, and really what you know is all the things you don't know, and it's a terrifying prospect. But through foundation, we bring you to the point of conscious competence so that you're aware of what you know, you're aware of what you don't know, and you know how to find out about it. And then as you go on through your career, hopefully, when you've been doing it for 30 years, you reach the point of unconscious competence where you probably pretty much know what you're doing. But you do move between the conscious competence and the unconscious competence during that time. Because the education of the doctor that goes on after they leave university is the most important part of the education. And it's 30 to 40 years worth. And it's ongoing and it never stops. So, on this journey, who is there to support you? We have the NEST team, so NHS Education Scotland, which comprises the Scotland Deanery, the UK FPO, UK Foundation Programme Office, which I'm sure you'll have heard from already. We have a lead dean for Foundation and a Foundation school director and manager, all of whom are based in Dundee. Each of the 4 regions has an associate postgraduate dean, and we all have consortium leads. You have your own Foundation Programme Director. The NES admin team are there to support you, and you will each have a named educational and clinical supervisor. This is the Scotland Foundation School team. So Claire Mackenzie's the dean, Fiona Cameron's the Foundation School Director and the Associate Postgraduate Dean in Dundee. Duncan Henderson is the Foundation Programme Board Chair and the Associate Postgraduate Dean in Edinburgh. Joy Miller's the Associate Postgraduate Dean in Aberdeen, and that's me a few years ago as the Associate Postgraduate Dean. They're all laughing at me in the audience because I'm too vain to put up a more recent picture. So, the Health Board is the other line of your support. We have the Director of Medical Education, who you've been introduced to already, the local education provider admin teams, and again, your educational and clinical supervisors. What's my role? My role, first, foremost, above all, is to ensure patient safety. And I do that through supporting you. So as your Associate Postgraduate Dean, I'm responsible for your education, your training, and signing you off as competent at the end of your 2-year programme. What do I want? I want you to have a fantastic training experience. I want you to really enjoy it. I want you to engage with it and love medicine as much as I do. So I will oversee your programme and your training, and with my team, I'll supervise your progression through Foundation, and I'll meet all of those of you who are struggling. I'm happy to meet any of you, but if you're struggling and you need extra support or assistance, I want you to come to me. Your Foundation Programme Directors will say the same, but I promise you that if you have a problem and you're struggling to get it fixed, come to me and I will help you find a way through it. So that's an open invitation. So I'll help those of you who face challenges because I'm here to support you all. In the West, we have 3 consortium leads because we have 441 trainees, and each of those consortium leads looks after 8 programmes, or 9 probably now. So they'll supervise your progress through Foundation, and they'll meet with those of you who are struggling, and again, they're there to help you. Each of you has a Foundation Programme Director, and I'm very keen that you meet with your Foundation Programme Directors once per block, just a short meeting, 10 to 15 minutes, to go over your e-portfolios with them and to talk to them about any challenges, also talk to them about the good things that are happening. And the Foundation Programme Directors are expecting to do that with you. So they are there to support and help you, to oversee the assessment process. They will sign you off at the end of FY1 and FY2. They will approve your study leave, so if you're seeking study leave, they're the people to ask, and they are there to assist you whenever you need help. Your educational supervisor is on the ground, and they supervise and manage your educational programme in each placement. So you'll make an educational agreement with them in due course, and they'll help you to set and achieve your goals through your personal development plan. And you should meet them twice a block, once at the beginning, once at the end, and they'll sign off each block. And your clinical supervisor oversees your clinical work, and they'll provide you with feedback during your placements. And again, they should help you set and achieve your goals, and you should meet with them at the beginning and the end of the block. Usually in the West, almost exclusively, the educational supervisor and clinical supervisor are the same person. The NEST postgrad admin team liaises closely with me to make sure that Foundation works and they manage the administration of all the programs. They're a wealth of information, and they will be delighted to help you if you've got any queries, and they're all there to support you. And the health board admin teams are a phenomenal help to us, and they manage foundation at each hospital. They provide a direct link to the foundation program directors, and they administer all the education programs. And again, they're there to help you, and they'll answer any questions or queries. Because our job is to keep you safe. And this is what it looks like. And there's you. And we are here to help you. I'd like to introduce you to the concept of buddies, which we're formalising this year. So I've already been in touch with the current FY1s, or last year's FY1s, and warned them this is happening. My intent is that every new FY1 is buddied up with an FY1 from last year. And the mechanism by which this is going to happen is that your FPD will email you and your buddy individually, and then it's up to you to take that forward. So they, I'm sure, will contact you, but feel free to contact them, and you have as much or as little contact as you want. But they are there to provide a little bit of peer support and experience for you. And I'm hoping that this process is going to roll so that this time next year, when I'm speaking to a brand new set of FY1s, I'm going to introduce the concept that you will be their buddies. So I'm very keen to hear from you across the year, whether it's working or not, and if you're happy to continue to be foundation buddies so that the process rolls year on year. And over the year, we'll be looking for representation on our national groups. So our Foundation Programme Operational Group, our Foundation Programme Board, our Foundation Doctors Advisory Board, our West of Scotland Trainee Forum and our National Trainee Forum, and our Foundation Wellbeing Collaborative. We'll want representation, FY1 and FY2, from across Scotland on in all of those areas, because we want to make sure that what we're doing is working for you, because it's fairly pointless otherwise. So what foundation training is all about is supporting you. So we need your input to make sure that we're doing the right things. So my thoughts on how to make the most of FY1. Well, you should grasp every opportunity you can to be part of the team and to provide patient care. You should make sure that as you do your clerkings and you're seeing patients, you're learning from every clinical case. You should be involved as you can be, and should help everyone because we're all in it together. I ask you to be courageous and to support each other, and fundamentally to ask for help and support whenever you need it, because when you ask, help and support will always be there. These are our NHS Scotland values: care and compassion, dignity and respect, openness, honesty and responsibility, quality and teamwork. And these are what we live our professional lives by. So I say to you, be kind to your patients, be kind to your colleagues, and be kind to yourselves. And that way, you'll enjoy your life as a doctor. And my final slide is some useful websites. I think we may well send these slides out if people want them, so that you've got a list of these websites. Okay, thank you very much.
Thank you very much, Caroline. And at the end of our next session, we will look to take some questions around the first two lectures, which you can access via the chat and the YouTube channel and the link. And one of the things that when we're looking at working together, it's absolutely true, we're all in this together to look after our patients. And you'll hear a lot in the next few days about patient safety and your safety. And when I talk through the Welcome to Your Health Board, we'll outline again, and there's a little bit of repetition, but we but that's on purpose. We want you to know who you call, who you ask, etc. So if I could have my slides up in if I could just have my slides up, that would be great. Thank you very much indeed. So, welcome to your health board. And again, I am the DME for GGC, however, I'm here to represent all DMEs, and my colleagues in the audience are going to remind me of that if I stray at all. So I'm Dr. Lindsay Johnson. I also happen to be an intensive care consultant in Glasgow Royal Infirmary. But what on earth is a DME, a Director of Medical Education? You may not have heard of this phrase or this person before, but we oversee medical education within the health board. So we liaise really closely with the deanery and we work for the board. Within GGC, we've got 1,500 trainees and 800 medical students. But as Caroline points out, the west of Scotland is vast. We have over half of the trainees within Scotland within the west. We also have a role in clinical fellow posts, and that's something that you may be looking for as you progress through your training. Relationships, loads of relationships, as you will have as you start your career in medicine. And these relationships are often lifelong. They are probably your best friends that you'll meet as your foundation, and your first jobs, you will meet people that you'll be friends with for many, many years to come. And not just doctors. You will meet nurses, you'll meet pharmacists, you will meet the whole MDT that will make your journey enjoyable, but also will be your friends. What are our key work streams within, as Directors of Medical Education? Well, induction, the quality control of medical education, educational governance, we'll talk, and Caroline's talked through that, and we'll talk through a little bit more about that, and clinical governance. And also, I know this is pretty obvious, but without trainers, there wouldn't be very much training. So we also have a role within the recognition and support of your trainers. And that relationship, the relationship between the trainee and the trainer, is exquisite, it's unique, and it is a relationship that can really help and support you as a doctor. So utilise that relationship. And of course, relationships, there are two sides. So trainee-trainer relationship, a somewhat important bond and relationship. A recent publication, Caring for Doctors, Caring for Patients, from the GMC, and this really outlines the fact that without looking after yourself, we can't care for our patients. And actually it looks at the ABC of you as a doctor, so autonomy, belonging, and also competence, and perhaps we add in confidence with that. And induction really leads the charge for this caring for doctors, caring for patients. But who looks after you? As a doctor just entering your profession for the first day and the first time. And like our patients, you are at the centre of what we do with your training. Our patients are at the centre of how we care for our patients. And as a trainee, you are at that centre. And there are two strands to this. There are two governance strands, clinical governance and educational governance. And your clinical governance sits within your team that you work with. So those are your consultants, your pharmacists, your trainees, your chief residents, and you will find chief residents in all of the sites within certainly NHS GGC, NHS Lanakshire, and when you're looking for your chief resident, within various other health boards, please ask, because lead and representatives for training as other trainees are there. And within the educational governance, Caroline has talked through the supervisors and the clinical supervisors, but we also have simulation leads, we've got college tutors. So just in that very first round of who's there, many, many names and many, many people. And when we look a little further afield, when we look at the clinical governance structures, you've got your peers, your consultants, but you've also started to get your clinical lead, your clinical director, who actually are your line managers when we look at these two governance structures, the educational and the clinical governance. We've also got clinical service managers, non-clinical managers are in there, again, looking after you. Just like the Associate Directors of Medical Education, the Foundation Programme Directors, again, all looking after your interests, both clinically and educationally. The list goes on. We've got chiefs of medicine, we've got directors, we've got associate medical directors, and we've got associate postgraduate deans and the directors of medical education. These circles just get bigger and bigger. And the key thing is that in each of these names is a person. There is a name of a person, and that person is interested in how you progress. We go further, and we've got, these are the leads within our boards. We've got the chairman, our medical director, our chief operations officer, our chief executive, and also for NES, we've got postgraduate deans, we've got NHS Scotland, and also we've got the Royal Colleges. So again, not just local, we've got board-wide, we've got NES-wide, and we've got national. And of course, overseeing all of this is the GMC, who is responsible for you as a doctor, but also your training. I don't think we can go much further today without mentioning COVID. As a group, you have been impacted upon significantly. In your fourth year, many of your studies will have had significant interruptions. Many of you will have started early in the fifth year. And as a group, the fact that some of you joined us a little earlier, there was recognition that there had been disruption. Disruption, however, the universities that you've all come from have ensured you are ready to start. So there is no doubt that you are competent. And the additional time was to allow a degree of confidence if you felt you needed it. So again, welcome to those that have just joined us today, and welcome back to those that started last week. And with COVID, there are several kind of new things that you will have been aware of as medical students. There are no three letters. I think we will never forget these three letters of PPE. Each of your own areas and your own clinical areas and health boards will have the policies and protocols for your PPE. If you're ever worried about it, ask someone. As you know, it changes significantly very often, which is why we haven't put up anything, because it may be different. Just the way even, for example, gowns are being used, there may be changes. So just keep up to date with that. The induction arrangements for COVID will be health board specific, and again, that's the west of Scotland. But this goes for everybody, and everybody in this audience. If you're symptomatic at any time, please do not attend, certainly this week, your induction. Arrange a PCR test and let someone know. COVID has affected us all. Every single person in this audience will have had an experience. There will be some significant challenges, and actually there's support for all of us there. And within GGC, and this is, I'm sorry, this is GGC specific, but there will be available psychological support in other health boards. If there are any psychological aspects, the acute care line is there for everyone. And I just wanted to highlight that to you right at the start, because although some experiences have been while working, there will be many experiences, some that will be shared, some that will be not, that may affect you. So I just wanted to bring that to your attention. Going back to caring for doctors, caring for patients, as I said earlier, induction really leads this charge. So what is induction? Well, it's certainly not just one day, and it certainly isn't just this session. It's a process. An induction probably takes 2 or 3 weeks, maybe even 2 or 3 months. How you feel on next Wednesday, a week today, you will feel very different in 6 months' time, and 9 months' time, and of course 12 months' time. But really it's about becoming part of the team. So ward shadowing, you're joining the team. Where is it going to be? Well, it's going to be in your ward. And we expect at least 2 full days of shadowing during this time. Because we want you to see how the ward runs, you know, what happens at handover, what happens during the day, what happens when you finish. And also you'll be taken through, depending on your health board arrangements, ILS and simulation. So you will get a chance to not just be a single member, an individual, but you'll be part of that team and you'll lead the team at times. Again, looking at shadowing your working day, look at your priorities and tasks, knowing your roles and responsibilities, knowing where things are. Where's the resus trolley? Where do you put your bloods? How do you get the bloods from when you've taken them to the lab? All these things that actually are inherent in a week today. But more importantly, Get to know the rhythm of the day and your well-being. The logistics, how do you get there? How do you park your car? Where's the kettle? How do you get a coffee? And actually eating and keeping yourself hydrated. The heat wave that we've had, my goodness, I think it seems to have slightly changed today. But the heat wave, keep yourself hydrated. We work in full air conditioning and we get dry. Wearing masks make you dry. Wearing FFP3 masks make you dry. So hydrate and eat. Appropriate rest, pace yourselves. You will, as a doctor, you will learn how to prioritise. It's very difficult when you just first start because, again, it's that unconscious competence and unconscious incompetence. You sometimes will take a little while to understand your priorities. But if you're not appropriately fed, watered and rested, you will not be able to look after your patients. So pace yourself. Manage your time, the time that you can. I completely understand that sometimes the destiny of your time is not within your own gift, but try and manage it as much as you can and foster some really good habits. And I can commend some websites with, for example, sleep management. Some of you will be great at sleeping. Some of you won't be so great at sleeping. And when you do shift patterns, that can have an effect. So Michael Farker has some fantastic podcasts. Take some time to do that. So foster some really good habits. And again, getting ready. There will be a lot of online, as this is, a lot of online getting ready. And again, it's health board specific. Your organisational induction will be there, your IT training. This is part of our lives, isn't it? So again, get ready, get up to speed to really get started in the 4th so that you can start to learn and start to look after the patients safely. And you will have statutory and mandatory training to do. Let's get that done. You need that done before you start. So that's getting ready. And as Caroline said, you've got through medical school, you've passed, you're starting as a doctor. There are no stupid questions. Please ask someone if you don't know. Whatever it is you don't know, ask. Please tell someone if you're worried about something. All of those circles that I showed earlier, these are people that are interested and can help you. And please listen if your colleagues are worried about something. And when I say colleagues, I don't mean just your FY1 peers, I mean your clinical colleagues, your nursing staff, your pharmacists, your MDT. If there's somebody that's worried about something, please listen. They may have seen something before, or they may have seen something that you haven't noticed. So please listen. And there is always someone to ask and to talk to. So in summary, clinical supervision, know who to call when you require clinical support. It may feel a lonely job as an FY1, but just like all of those circles, there's an entire team with you at all times, day or night, Monday or Saturday. There is always someone as an FY1 to call. Raising concerns, know who to call if you have concerns. These lists have people in them that can help you. And the majority of issues can be resolved locally. And all issues can be resolved ultimately. And stay well. Hydrate, eat, and sleep. And I hope you have a fabulous first week, and we all look forward to working with you starting a week today. Thank you very much indeed. Thank you very much. And as part of your welcome to the Health Board, and on behalf of the West of Scotland Health Boards, I'd like to introduce Dr. Jennifer Armstrong, who is our Medical Director here in NHS GGC. Thank you very, very much.
Thanks, Lindsay. Well, good morning, everybody, and thank you very much for choosing Grace, Glasgow and Clyde and the other 4 health boards in the West of Scotland for your foundation year. We're delighted to welcome you to your first year of a doctor. Now, as Professor Taylor said, it's quite daunting as you're facing your first day on the wards, so I wanted to share this story with you. In August of 2019, I decided to take part in a mini triathlon. Now, for those of you in the West of Scotland, you may know Gourock, and it was a Gourock triathlon, and it was in the open air pool there. So I'm okay at running. I run 4 times a week. I can cycle, but my swimming is pretty poor. So for the 3 or 4 months beforehand, I would go to Bellahouston Sports Centre and to the adult swimming classes to learn how to do a front crawl. So I appear in Gourock I'm fairly confident. I know I'm not the best, but I can just get through it, and it's a half-mile swim. As I got there were 6 lanes with 6 swimmers in each lane, and my lane looked as though it had Adam Peaty's little brothers in it. It was daunting. So I get into this lane, and I start, and you've got 30 seconds to start, and the idea is, for those of you who know about this sort of thing, if someone touches your ankle, that means you're slow, you have to let them go and move in and let them pass. So we start, and I start my crawl, and then suddenly I am a hot, sweaty mess. Everybody is almost gnawing away at my ankle. I am drowning. My goggles are full of water, and I've forgotten everything I knew. And in fact, my 2 sons, who are supposed to be supporting me, in their mobile phone footage are saying, "God, you think Mum's had a stroke?" because I was so bad. And at this point, I'm reduced to a doggy paddle. So I get to the end after I've got 24 lengths to go, and I get to the end of the pool, and I look back, and it's like a tsunami coming towards me. All I can see is 5 swimmers, legs, everything, with this tsunami wave coming towards me. And I thought at that point, wait a minute, so hold the boat. I thought, I'm Medical Director of Greater Glasgow and Clyde. I've done worse than this. And I'm also been training for 3 months, and they've been trying to train me at Bellahouston. So calm down, stop panicking. So I began to do stroke, stroke, breathe, stroke, stroke, breathe, and just ignored them. Now, I have to say that no one ever nibbled my ankle again. I didn't catch any ankles myself. When I came out the pool, I was delighted to see that I was second last, and there was 1 swimmer left who they were nearly sending out the lifeguards are, and that swimmer was my husband, who had taken part in it as well. And it was the first time I'd ever beaten him at anything, so there was pleasure in that. But my point of this story is, don't panic. You will find that there will be days when you think, gosh, this is quite difficult. Go back to your training, and as every speaker has said before, there is lots of people to help you. So in Greater Glasgow and Clyde, for example, there's over 3,800 senior doctors. And one of the great privileges of being the medical director is you get a ringside seat at how good they actually are. They're sitting in front of me today. They are very, very well trained. They're very good at patient care. They look after nearly 1.2 million people, 2.7 million in the west of Scotland, and even our national services. There's every kind of doctor in Greater Glasgow and Clyde, and it is almost humbling to see them, how good they actually are. Now, as Lindsay said, there is 1,500 trainees at any one time in Greater Glasgow and Clyde and across the west of Scotland, and you begin to see them blossom as they go through their career. And one of the pleasures of medicine is that there will be something for everybody. You will find a niche. I was about to say this morning, there's lots of different specialties, but there's a preponderance of medicine for the elderly. You can never have too many consultants in medicine for the elderly. Let's hear it for you. There's also a lung cancer clinician here as well. And as Lindsay said, she's from critical care. I'm a lowly public health consultant, and it is as somebody, a neurosurgeon said to me, and this is somebody I trained with way back in 1988, in Glasgow Infirmary. He's now down in Plymouth, and he said it was the year that public health became interesting. And I always thought it was interesting, but actually he was talking about COVID. So in mentioning COVID, I wanted to say in absolute recognition, you see these junior doctors and the senior doctors have managed 3 waves of COVID, and they have been absolutely fantastic. You watch it, you see it as we were doubling and increasing capacity right across mental health, primary and secondary care, as we were dealing with thousands of patients with COVID, as we adapted, as we vaccinated, as we got new treatments. So you join the NHS at this period. Now, what do all of these doctors have in common with you? Well, they all had a first day. My first day was in Glasgow Infirmary in 1988 in the renal unit, and I picked up, our induction was, I picked up a page and it had a wee note stuck to it saying, have a good one. And that was it. And I picked up this page and it's ringing its head off, thinking, oh gosh, what do I do? So they've all got a first day in common with you, as you will have, but what we don't have in common with you, and Lindsay mentioned this, is that you've had a pretty tough time in 5th year, going through a COVID-related 5th year. None of us have experienced that. And when I was speaking to some of the consultants who teach you, they wanted me to say that they take their hat off to you because you've made it through a pretty tough year to be here today, ready to start on the wards. And so therefore you have shown that you're resilient, and you have shown that you've got mettle, and we really admire you for that. So as I said, to quote Dickens, you've joined the NHS at the worst of times. We've had COVID surges. We're going to have a difficult winter. But also it's one of the best of times, I think. You can see the NHS is like a big oil tanker. And almost with COVID, we've gone from oil tanker to jet ski. We have been innovating all over the place. And many of the changes that we at the board had thought would take 3 to 5 years to put in have come in 3 to 5 months. So there is massive change from COVID, much of which we think we'd like to keep, much of which we certainly don't want to keep, but things which you will be well placed in your career to take forward, the digitalisation of the NHS, the way that we've been managing with apps and various other things are quite new to us, as well as we're more looking at how we can actually change unscheduled into more scheduled care. But you will see that as you go through your career, and you're probably a lot more tech savvy than the rest of us are, so we're looking forward to you joining us. I wanted to read out something to you, which actually was, we've talked about the main business of the NHS is treatment of patients. There's training, there's teaching, there's all of the other things we do, but treating patients is at the heart of it. And I got an email from the GMC now as my own professional registration, plus if you've got 3,700 doctors, you want to keep the GMC happy. So every email I get from them, I open them, I urge you to do the same. Anyway, this email appeared on the 21st of July. And it was from Dame Claire Marks, who's, many of you may know, she is the President of the Royal College of Surgeons. She then is the chair of the GMC since 2019, one of the UK's first orthopaedic female surgeons, and has had a long and illustrious career. And this was the email I got, which I thought was quite moving, and I'm going to read just an extract from you. I'm stepping down from the GMC, having recently been diagnosed with pancreatic cancer. And then she goes on to say, since receiving the news, I've been reminded once again of the importance and power of kindness in everything we do as doctors. Now as a patient, I've appreciated that kindness from my medical team and found its impact to be profound. As doctors, the interaction we have with our patients are a crucial part of the medical care we provide. Our empathy and professionalism shape a patient's experience almost as much as our diagnostic ability or surgical skills, and they shape our own experiences as clinicians. So what I want you to think about is as you go through your medical career, you will get used to going into the wards and it will be another day, but that patient, particularly those who are under stress, you're about to give bad news to, they will remember that. It will have a profound impact about the way they handle their illness going forward. So that's why everyone keeps talking about being kind and being compassionate, because that's almost as important as your diagnostic skill. So I suppose, in conclusion, I suppose don't panic. Don't be like me with everybody coming at you. Calm down, go back to your training and take it easy. If you need help, shout out. And remember that Dame Claire Marks, her email, I think that was a very profound email, and it was a very difficult email for her to write, given the diagnosis she just received. So as everyone says, you will find your niche. You will find there's something for everybody in medicine. That's why I find it so fascinating. There's different ologies, different doctors right across GGC in the west of Scotland. Keep yourself fit if you can. I do running. Probably what you've not heard from Lindsay is that she has horses. She does horse riding, and she wouldn't mind you saying, I'm sure, well, I didn't ask you about this, but she went to Texas to manage cows on horses. She was what do you call it? A cowhand. I think it was a cowgirl. Cowgirl. She's a cowgirl. So you have to find something that's not weeping into your whiskey bottle by yourself at 3 a.m. that keeps you going and keeps you happy. So I wish you all the best next week. I am sure you will turn into fantastic doctors. You certainly have a great cohort right across the west of Scotland of doctors who can help you achieve that. So thank you very much.
Thank you very much indeed, and I now realise no secret is safe. So thank you very much. That's us drawing to a conclusion this very first session, and we've got plenty of time to answer any questions that you may have. We're just looking to see if there's anything on the chat, and I know that we've got one question from within the audience, and if you'd like to ask your question, and I'll repeat it.
Just in regards, can we wear scripts on the day we turn up to our station?
Thank you very much indeed. So the question is around scrubs. And again, this came up last week, And during your working within Glasgow, scrubs are not mandatory. However, you may wish to buy your own scrubs. As an anaesthetist and intensive care consultant, I've lived my entire life in scrubs. They're incredibly comfortable. And if you want to buy them, you're absolutely welcome to it, and you're welcome to wear them. And the caveat is about laundry. So launder at 60 degrees. And that you're absolutely welcome to wear that. That's within Glasgow. You should really check that with each of your individual health boards as to what the uniform policy is. Thank you very much for that question. Anything else online? Any other questions? Nothing? Not yet. Okay. But we're around all morning. If there are any questions that you'd like to put onto the channel, we will be extremely happy to try and answer them. And again, if they're health board specific, liaise with your teams, your local teams. I'd like to thank all the speakers for the first session. Thank you very much indeed. And I'll hand over to Caroline to take you through the next part of the morning Welcome to Foundation. Thank you very much indeed.
So, hello again, everybody. So, this part of the session is to allow me to talk to you about FY1 induction in the curriculum. I'm just going to pause for 1 second. This isn't the right set of slides. So this... Can we just cut the feed for 1 second? No. So it's it's got a blue background and it's called. I sent them yesterday. No, that's not it. I'll just wing it with those if we need to. Michael, it's okay. I'll just use these. We're back on? Okay, great. So, apologies everybody. What I'm here to talk to you about now is the new 2021 curriculum that you're all going to be working with. So, as you know, your foundation training programme consists of your clinical posts and a structured educational programme. And About every 5 years or so, the curriculum gets renewed, and the new curriculum is coming in as of now. And it's been developed under the auspices of the Four Nations and also the Academy of the Medical Royal Colleges. So, I've discussed the aims already. It's a 2-year programme. We know who are here to help us, your supervisors, your foundation programme directors and the administrators. And what you need to do over the next 2 years is to develop your competence, and you'll be using TURAS ePortfolio as the platform on which to demonstrate this for us. So that at the end of each year, you will have something called an ARCP, which is an annual review of competence progression. And at that point, we are able to make a judgment about whether you're competent enough to be signed off for the year. And just to give you advance warning of the date, you need all of your information up on the ePortfolio by midnight on the 31st of May. So if you remember nothing else from this little talk I'm doing now, remember that date. Everybody write it down, midnight, 31st of May, because you need everything up by that point, because anything that's not up by that point won't count for your ARCP. So, when you open your ePortfolio, the first thing you need to do is accept your post and sign off your health and your probity declarations. And then it will be a situation of putting forward foundation evidence, and that is evidence of your safe practice, such as your supervised learning events, such as information from your placement supervision group and your supervisor's reports. Also, evidence of team working, and we evidence that through a team assessment of behaviour. And, importantly, evidence of learning, which is attendance and recording of your mandatory sessions, the core learning sessions that you do, and also mandatory but non-core learning. And this slide shows a list of the supervised learning events which you will be working from. So mini-KEX is a mini clinical encounter, and what you'll do is you'll perhaps give information to a patient, or you will examine a patient on a ward, and you'll be observed doing it, and then you will be able to reflect on how that's gone, and your trainer will reflect on how you've done it and feedback to you. The DOPS is a direct observation of procedure, which is taking blood or putting a catheter in, something like that. A case-based discussion is where you sit down with your trainer or with a more senior colleague, and you spend a little bit of time discussing a case that's happened, and they reflect back to you and you reflect on your learning from that case. Relatively new are the Learn and the Leader forms. The Learn form is a more generic form that you can use to demonstrate any of the evidence of the other forms, but also things like attendance at simulation. And the Leader form is something to use where you think you've shown specific leadership skills. And finally, we have the Developing the Clinical Teacher, which is about you becoming a teacher as well, because part of what you are as a doctor is a teacher, because it's an apprenticeship training, and we all spend our training passing down onto the next people, and they go through and they pass down to the more junior colleagues, and that's how it's always worked. If memory serves me correctly, you agree to do that when you state the Hippocratic Oath. So, for sign-off for ARCP this year, there are no minimum number, no mix of SLEs. But what we want you to do is provide sufficient evidence that you have covered the curriculum. And the curriculum is divided, as I'll describe, into higher learning outcomes and foundation professional capabilities. And what you'll do is link each bit of evidence to the foundation professional capabilities. To give you a guide, because everybody likes a guide, it's too nebulous to say, oh, there's no minimum number, do what you think you need to do. What we would advise is to do about 5, minimum 5 per block, will allow you to comfortably cover the curriculum. So if you keep that in mind, roughly 5 SLEs per block. The placement supervision group is an important addition this year. This is where we will be gaining feedback from your senior colleagues. And it's about your clinical and professional practice. Your supervisor identifies the members of this group, and it's going to help inform the end of placement report. So it's an excellent opportunity to show excellence in your training. And what happens is the supervisor emails out to their colleagues, and by the end of the block, the colleagues fill it in, and then the supervisor will feed back to you the responses that they've had. You'll need to do one placement supervision group per year, and it can be in post 1 or 2. My advice, do it in post 2. Each block, you need a supervisor's report. So you'll have 2 recorded meetings with your educational and clinical supervisor per block. One's an induction meeting at the beginning of the block, and the other is a sign-off meeting. And to be successful at ARC-P, you need, by the 31st of May, midnight, 3 completed combined supervisors report, of which 2 must be satisfactory, including the last one. You need to acknowledge these reports, so you need to have acknowledged them by midnight on the 31st of May for it to count. Once per year, you'll be doing a team assessment of behaviour, which is a measure of your team working ability. You do a self-rating, and then you personally seek 10 raters, and there's a mix of raters advice, and you'll find that information on the e-portfolio. And this should be done either in the first or second block. Again, my advice, if you want clear suggestions, is to do it in the first block. And then there's the learning part of the curriculum, and it's divided into your core learning and your non-core learning. And the core learning is the delivered foundation education programme, and it's mapped against a nationally agreed syllabus. So that's a UK nationally agreed syllabus. And you need to demonstrate 30 hours of learning. Now, when you're being taught for these 30 hours, it should be bleep-free. You record it as core learning on your e-portfolio, and because it's mandatory, if you're struggling to get there for whatever reason, let your FPD know early so that we can do something about it and something to help you. In order to facilitate it, the sessions may be repeated at different times and in different locations. So we can use some e-learning if you miss some of these subjects. It includes simulation. It can include some of the hours from induction, not these 4 hours this morning, but it can include all your simulation, your FY1 simulation. It doesn't include ILS and ALS. It doesn't include departmental teaching. And it can be delivered by teams. And this year, just an additional series that we have for you is called the Glasgow series. And it's a series of podcasts that took place over this last year where a couple of our FY2 trainees chose inspirational physicians with memorable cases and developed a series of half-hour podcasts, and we've agreed that they can be counted towards the mandatory teaching hours, okay? Because you'll be able to listen to them. I've listened to them all and I found them quite inspirational. My challenge to you is to spot the speaker in this room who is part of that group. And it's not me. So you can listen to them in the car, but log them against your core mandatory hours if you need to or you wish to, and they will count. Half an hour for each one. Non-core learning, this is another 30 hours that you need to log. Again, the mandatory aspect is that you have to log 30 hours of learning. You can pick what you do though. You can count the Glasgow series to non-core if you wish. You can use departmental teaching. You can use hospital or departmental meetings, grand rounds, morbidity and mortality meetings, journal clubs, and you can count 5 hours of ILS or ALS towards this year. And so it should be recorded on the e-portfolio as non-core using your reflective log. It doesn't include anything that you do during tastes though. So, to go back to the curriculum then. The new curriculum is based around 3 higher learning outcomes, and these are they. So, higher learning outcome 1 is you as the clinician. So this is about clinical assessment, clinical prioritisation, holistic planning, communication and care, and continuity of care. And you should be using mainly your supervised learning events as evidence for this part. Higher learning outcome 2 is you as the healthcare worker. So it's about integrating with the whole of the healthcare workforce. So it's sharing the NHS vision. It's your fitness to practice. It's upholding the values. It's quality improvement. It's engaging with teaching and teaching the teacher. And then higher level outcome 3 is you as the professional. And this is your professional requirements and expectations, and the expectations of you. So it's ethics and the law. It's your continuing professional development. And it's about understanding medicine in its greatest form. And within the curriculum, we've really boosted up the focus on several aspects. It's not just about physical health, it's about physical health, mental health, and social health. And this occurs across a wide variety of areas: community or primary care, acute or chronic hospital settings, mental health settings, health promotion settings. And you can garner evidence in all of these settings. And what's going to be important in terms of your ARCP is you providing evidence of both mental health engagement and physical health engagement. So, for example, for your FPCs, you need to provide evidence that you've had both learning in mental health and physical health. So for an acutely unwell patient, for example, you could use a cardiovascular deterioration for the physical health and an acute confusional state for the mental health. For the FPCs, as I've suggested, your supervised learning events are going to be most valuable for you as the clinician for higher learning outcome 1. But reflection and learning is also important, and I think reflection is going to be very important. We need to see at the end of the process that you have learned from what you're doing. So we have 13 FPCs, and what you need to do is you link your evidence to the FPCs and then it accumulates to the rest. And we need to cover all areas of Miller's pyramid, but primarily the SLE shows that you know how to do it and you know what you're doing. Your reflections on simulation shows that you're getting the learning and you're able to undertake the skills. And your learning and reflection tells us that your knowledge is increasing. These are some screenshots of what it might look like. And the summary narrative. This is an important new aspect of the e-portfolio this year. This is the first time we've done this. And the point of this is to get you into the way of planning your own continued professional development. Because it's what we all do. It's with you for the rest of your professional lives. So it's a good time to start to get used to it. So for each of the 3 higher learning outcomes, you need to present a piece of work, which is about 300 words by the end of the time, but it can be done cumulatively, to demonstrate the rationale for the evidence you've picked and how you feel you're covering that. So this will be assessed and your foundation programme directors will read that. In FY1, you need to demonstrate some engagement with quality improvement, but as you have to do the JMC National Survey and the Scottish Training Surveys, these can count, so make sure that you upload the numbers that you get when you've done them. And there are some other small requirements. You have to have completed successfully your prescribing safety assessment by the end of FY1. Now, the majority of you will have done it in medical school, so upload your certificates. If you haven't done it, you'll be offered the opportunity to do so during FY1. And for FPC2, which is acute care, you need to specifically evidence that you've recognised and treated the deteriorating patient using an A2E approach, that you've undertaken quality CPR, defib, simple hour manoeuvres, and that you've facilitated initial leadership and effective team membership. All of those can be gained from doing your ILS course. So, for your ARC-P, which is the thing that's going to matter to you, remember that date, midnight 31st of May. This is when you need all this evidence, right? 3 combined end of placement reports acknowledged by you. 1 tab, probably in block 1. 1 placement supervision group, probably in block 2. Your PSA certificate. Your 30 hours of core learning and your 30 hours of non-core learning as a minimum. Your engagement with quality improvement. Your curriculum evidence, remembering to balance mental and physical health and to specifically evidence FPC2. Your completed summary narratives. Your engagement with the programme and your absence declaration. You do all that, you'll sail through. So, a final word about tasters. These are an opportunity for you to explore your career choices. You can do up to 2 specialties, maximum of 5 days in each, and it can be done during the final block of FY1 or within FY2. You need to apply to your foundation programme director to do it. It's usually done within region. We're never going to let you do it overseas. But very occasionally it can be done without region, but it has to be in this country, and predominantly, unless there's a really good reason, it needs to be done within region. And all the information you need will be on the Scottish Foundation School website. So, thank you very much. Do you have any questions?
One question from YouTube. Is it a document or place where we can find all this information summarised?
It's all on the Scottish Foundation School website, yes. And you will be emailed about it on a fairly regular basis with reminders from the Foundation School Director and also from your Foundation Programme Directors. So no worries about that.
Sorry, someone asked me, is ILS needed for ARC?
So this year, you don't need a specific named certificate, but you have to specifically demonstrate those competencies. So ILS is a very useful way to do that. And if you don't do ILS, you'll have to find a way to specifically demonstrate those competencies.
Could you just describe study leave again for FY1s?
So FY1s don't get study leave per se, apart from their taster week in the last block. So they can request study leave for the last block for FY1 for a taster. Other than that, they don't get study leave, but they will be released for their mandatory foundation training, which usually happens once a week at a lunchtime. Okay. When you get into FY2, then you can request study leave.
And annual leave was the other question that always comes up.
So annual leave is a contractual arrangement with the health board, and it's requested from the health board and not through the foundation programme directors. And at FY1, FY2 level, it's 5 weeks plus stat days. Okay. Right, I'm going to hand you over to Dr. Joseph Estran, who is one of our consortium leads. Thank you very much.
Thank you very much, Caroline. So this is a bit tricky because we've got no audience, and I normally can read the floor a little bit, find out who's getting bored, who's falling asleep, and I normally dress up. I can't even see if you can see my outfit before I come, so that you can remember the ridiculous man that stood in front of you with a cycling outfit in this institution of sober seriousness. Because I think that's my influence, and I think that's the only reason Caroline asks me. So anyway, first I'm going to start with a little story. I'm all about stories. I've only got one slide in my talk, so it's all about stories, and they're all a bit relaxed. So you don't need to make any notes. All the information you need is in that website that Caroline has told you. But imagine me yesterday when we realized that I'm one of three consortium leads, as Caroline's pointed out, when one of the three was unable to do the talk that Caroline just did. And I knew it was going to be me having to include that, or maybe Caroline. And so imagine my happiness when my boss says, I'll do the hard stuff. You just stick to your easy one. I thought, what kind of boss is that? So I tell you that story because sometimes it's easy when you're at home, I presume in your pajamas, drinking your coffee, relaxed, think, yeah, they say they care, but they probably don't. But actually, Caroline genuinely cares. If she cares about me and makes my life easy, imagine how much more she cares about you. The final thing I would say is all of the people that have spoken and are going to speak have kids. And we're all of an age where our kids are closer to you in age. And so there's an element of us, when you're in bother, or when you're upset, that thinks, really, that could be my child, and we invest in you with a similar sort of ethos. And try and remember that when you're unhappy, sad, or not in a good place, because genuinely we're invested in you. Okay, so enough of that. I'll come back to that bit. I'm Joe Silvestrin. Everyone knows me as Dr. Joe because Silvestrin is a bit long to pronounce. I secretly want to be a comedian, a stand-up, like Ramesh, fellow brother Sri Lankan, but, that's not going to work. Caroline, as I've said to you, is part of my foundation school team, an incredibly supportive, lovely bunch of people. My wife of 25 years is a little bit more old school. She gave me some direct instructions this morning. She knows I like to wing it. She knows I like to just see what the floor's like and manage it. She knows that I forgot to mention her during my wedding speech, and so made me write something out. She's not forgiven me in 20-odd years for that. Now, and she gave me 3 specific instructions. She said, do not wear the lycra. I didn't say always listen to her. She said, COVID hasn't been that kind to you, and now I see it. And particularly, when a triathlete was standing up here with a triathlete's physique, I was a bit self-conscious. But I did listen to her, and I put on my mountain cycling shorts. So this is to the Dumfries crew. You've got beautiful cycling down there. Remember to do some of it. It's amazing. Don't break your arm, because it'll take you over the 20 days. So wear protection when you go on those trails. Those of you in Ayrshire and in Forth Valley, there's some beautiful cycling up there. And those of you in Glasgow, there's lots of cycle lanes. So use the bike, it'll make you happy. The second bit of her advice was don't drink the coffee. Now, she knows that I'm a bit caffeine sensitive, but when you're here and everyone looks a grown up and they're having coffee and you want to belong, and a Sri Lankan boy growing up in the 1970s, I know all about trying to belong. You do what other people are doing, so you kind of look like you fit in, particularly when you're dressed in an appropriate lycra and they're all looking smart. And I have done that, but it makes me even more hyper than I normally am and unbearable, so she said, don't drink the coffee. Third thing she's written down is, do not use the word woke. You're too old. So I've listened to all of that.
You're so woke.
Now, this talk about diversity, resilience, and well-being was not something that we ever had in my generation, but it is very much in vogue at the moment. But it's so much in vogue that it gets dull. You all switch off, you think, I've heard it, whatever. So I'm going to do it slightly differently. I'm going to use, this is my one slide. Now, I love film, but there's been very few films of late, and I try and use a film that everyone has seen so I can illustrate what I think your life in this first year is like using a film. but I've gone back to an old favourite of mine, The Lion King, because I think it illustrates your year, and it illustrates the characters you're going to come across, and it maybe gives you an insight when you're on the shop floor as to what it's going to be like in real terms. Okay, so you have to remember that in this film, you are Simba, and I'm presuming all of you have seen The Lion King. I've looked at the list. I know some of you have trained abroad and may not have, so I'll give you a plotted story. I grew up in Sri Lanka for 10 years, and when I came here, I'd never seen Greece. And according to my wife, that's like a must-see. I've seen it now, and I wish I'd never had. But The Lion King is different. It's really a good film, so you must see it if you haven't. And remember, you are Simba. And so what's the issue with Simba? So Simba is this lion cub that is born, is going to inherit the land, and he's brought up by his parents, and they show him the land and all that could be his. And that is you. All of you, all 400 and something of you are different from each other, but you share something in common in that you have been trained, you have abilities, and you have skills. Now, I've heard so much about talent about the Olympics. I'm an anti-talent person, because it's nothing to do with talent, I think. Well, we can discuss it when you meet me, but it's nothing to do with talent. It's to do with opportunity, and it's to do with hard work. And those of you, and I've seen some of your CVs, they're incredible. You have some incredible CVs, some of you, and I would never have got into medicine if I was competing with you to get into medicine. But some of you, maybe a bit more like me, are thinking, that wasn't me, maybe I didn't do so much. My old school days, I copied my mate who had neat handwritings, photocopied notes, and managed to scrape through. Wasn't the rising star, but I'm still here, and I love my job, and I love the team that I work with. And so each and every one of you, when you look within yourself, there is an opportunity for you in medicine. It is our task to help you to find the right job for your personalities and your journey, and that we'll do as best we can over the next couple of years. So, Simba starts life full of hope, full of excitement, which is you lot now. A bit of you is thinking, give enough of this chat, I need to save lives, how do I get started? So, Simba goes off, impatient and for excitement and seeking adventure. And the first thing that happens in Simba in the story is that there's death. And the death in this situation is of his father who comes to save him, but death. And the reason I talk about death is that I hope in your young lives you have not already had to face it, but I know some of you may. But you will all in this first year face death, and it will all have an impact on you. And because you are still human, kind, and retain your humanity, you will be affected by it. But some of you will look around you and will see that others seem to be less affected. They seem to move on to the next patient. They seem to move on to the next task without needing time. And some of you will feel, all of you will feel, oh, this isn't for me. I'm not like them. But I assure you that you are not abnormal. You are the normal. You are the human side. And we need you to remind us sometimes of humanity and show your vulnerability, and will allow us to help you, and you'll be helping us too. So remember that when that episode happens. But in Simba's story, he feels responsible for the death. He carries that burden within himself and cannot cope with the rest of the time left with the pride because of his shame. I talk about all those things because when incidents happen, you always feel and take it very personally, and you need to use those opportunities to share your pain with people, not hide it and try and cope within. Because I could almost always guarantee you, you are not responsible for that death, but you will feel it as if it is. And so that happens to Simba. He goes off and he runs away, leaves the farm, leaves I don't know what a pride's group. Anyway, leaves the pride, goes off on his own, and is a bit lost. And in that journey, he comes across some friends, unusual friends, different from him, So we've got those two characters here. I'm not sure if you can, have I got a pointer? The pointer, beautiful. So you've got the characters that end up being his friends for life and through the rest of the journey are really these two characters here. And you can see that they're very different from him. And this is my chance to chat to you about diversity, because they're different but the same. So of your 400 and something, each of you is different. Some of you are of colour, some of you have different identities. You may or may not wish to share it, but sometimes when you feel different, you can feel the burden of being judged differently. And so I cannot hide the fact that when you're different, your journeys are different. But what I will say to you is, if you're willing to share that journey, you will find more commonality from the people beside you than differences. And there will be people who have walked the same journey as you, who can help you to walk it with less harm and more kindness, if you give us the chance. Okay, so that's what happens, and through his life, with the help of his friends, he then gets stronger, gets better, and comes back to the pride, but then is faced by challenges. Now, the challenges come in this context with the hyenas. Now, they are always nipping at his heels, challenging him, causing problems, and in your environment over the next year, that could be just about anyone. Now, you will experience acts of unkindness. It may come from your peers. They're a bit annoyed that you're not doing your IDLs at the rate that they need to be done, and they feel they're carrying a burden. It may come from the nurses who are feeling pressure to get beds cleared or other things. You're not paying attention to you made mistakes in your discharges or your prescribing. It can come from your seniors who feel you're not doing your work fast enough, or you're not paying attention on the ward round. Why weren't you on the ward round? They can all be small acts of unkindness, microaggressions that you perceive and can make your life challenging. I put it out there because that's what happens. They're not unpleasant people, they're not unkind people, but you will experience acts of unkindness. And we cannot protect you from that, but you have to have an awareness of it and understand how you're going to deal with it at the time. And my tip to you is a little bit like Jennifer's tip to you about when you're in a panic, is to pause and to breathe. Try not to react instantly, count to 3 maybe before you react, and try, if you can, to say what you see. If you say to the person, I seem to have upset you, then they will understandably, that acknowledgement allows them to step back a little bit. Try your best not to react and to reflect what you're met with, because that leads to a bit of escalation. And all that happens is, although transiently it might feel satisfying to reply to someone firmly, that burden stays with you a lot longer than forgiving the interaction and moving on. And I speak from years of experience. Okay? So try that. It won't be easy, but it will help. Now, the other person is here. This is Scar. Now, he is the bad guy in the movie. He's the person who, in this scenario, has a malicious intent and is intent on doing harm because he wants to have Simba out the way. And there are people that you will come across in your journey that make you feel like that. That you feel these are people, not microaggressions, but someone who has it in for you. Someone who doesn't like you, someone who treats you badly, who doesn't show you any respect. And that will happen. We try our best to prevent that, but people sometimes, through their own coping strategies, who have not had kindness shown to them, can become embittered and twisted, and sometimes can behave badly. And it is our whole intention and aim to change the culture of medicine by referring to kindness throughout all of our talks, that by avoiding that conflict, that you will not become like those individuals who you will meet. And we will help you to find strategies to deal with those people if you share it with us. You are unlikely to be alone. I cannot promise that every individual who behaves badly will have some disciplinary action forced upon them and sacked or sent away, because some of those people have some incredible skills and some creativity, but to make change we have to do it iteratively and sometimes slowly. But we need to first hear about it, and then we will support you, and ideally we will support them to enable change. But sometimes it happens slowly, sometimes it can be hard. Now, I come to the two supporters, the supervisors, and they're in two groups. The bird, Zazu, is always there. Sometimes a little bit of a pest, sometimes a little bit instructive, sometimes a little bit restrictive, but they are there to guide you. They're very much on your side and there to help you through this journey. Sometimes they give you messages you may not wish to hear, as kindly as possible, but if a bit like my mum, you're driving and at the age of 90, and you don't think there's anything wrong with your driving and all the car crashes are happening behind you and you have no insight, sometimes someone has to say to you, Mum, maybe it's time you gave the driving license up, because you're not looking behind. So sometimes people, your clinical educational supervisors, might need to take you to a side and say, look, this is happening. So they will try, if I can get them, and we try and educate them to do it gently and kindly. But you also have to hear what they say, because sometimes it's hard to hear. We defend our position emotionally and then justify it intellectually. But sometimes you have to have an openness to say, okay, maybe there is some truth in it. So they're there, and I think I'd like you to visualize your educational clinical supervisors in that role, and they include your clinical team. They're there all the time. They might not always be great message, but they're trying to their best to help you. And then the most important person is Rafiki. Not there all the time, comes and goes through the story, but always provides the guidance and always provides the value and sees the bigger picture of Simba as a valuable commodity and as a person that has real qualities that will in the fullness of time mature to be the king. And that is you, and Rafiki is the foundation school, embodied in Caroline, my boss. So, it might not be the flattering analogy she likes, but Rafiki is that concept, and I want you to genuinely believe it and understand it, because that is the role we play. And ultimately, and I've said this before and I've said again, ultimately, I would love you all to have a successful career in medicine, and there is a place for each and every one of you. But mine and Caroline's priority before that is to make sure that you as people are valued. And if at the end of this year or during this year you feel medicine is not for you, come and talk to us. Our priority is to make sure your well-being is more important than keeping you at work or making sure you're a doctor. If you find in this journey that this is not for you, we will help you and support you to maximize on your strengths with no regret. Okay? So thank you very much for your time. I hope you enjoy your coffee at home. And I have to say, I'm loving the pajamas at work. So if you are allowed and you do have that opportunity, you can cycle in your little civvies and then you can just get into your pajamas. It's a lovely way to be.
What's your advice to wear pants?
So it's a fair point. Never forget the pants. It's very embarrassing if you do. Never happened to me so far. Thank you very much. I'll take any questions. Great, thank you.
Thank you very much indeed for all the speakers, and we're now going to break for coffee. We hope you've put the kettle on at home, and we're also going to show the QR code again, because I think the attendance QR code, there was a little problem with it just slightly earlier, so we'll just put that back up again for you to see. We'll be back at 11 o'clock. Enjoy your coffee, and thank you very much indeed, and thanks again to everybody here. Thank you.
And that's also down on here too. So let me just quickly move this over to
Beautiful.
Within the last 6 months, I just don't wear it much when we're on the meetings.
I was just gonna, can you hear me okay? Is that us ready to go? Good morning, everybody. All of you at home, all of you in various lecture theatres. My name's Elizabeth Uman. I am a DME consultant in the Queen Elizabeth and also FPD for W1. I will come across some of you that work in the Queen Elizabeth because I do some liaison along with Ian Reeves, who's presenting a bit later on, who also does some liaison. This talk is a little bit about how your year in foundation goes and some tips that Victoria, who's in FY2, who's just finishing FY2, is going to share with you as well. Now, it seems a long time ago, a year ago, when the current FY1s who are just about to go into FY2 started, and what I would say is it's been a very fast year. They've learnt loads, they've been very innovative and done loads of things this year that we hadn't asked them to do, like the podcasts, teaching online, working together and cross-covering areas and being redeployed. So Foundation has been a great experience for them. I've asked them for some tips, and the things that they have said are similar to what you've heard already this morning, which is to say that it's a hard year, but it's a good year and you get lots of experience and make lots of friends. The main things that have come out of their tips are not to panic, which people have mentioned before. When you've got a situation where you're feeling panicky, just take your time, and there's always someone to ask. They've said there's FY2s, there's nurses, there's core trainees, there's regs, there are consultants, there's supervisors, there's lots of people to ask. They did say one of the first things that they would try and find out if you are in your shadowing bit just now is when you're on a ward, just to know how to escalate on a day-to-day basis and how to escalate when you're on call. So know the phone numbers of the deck phones or know the pages. And the other things they've said is to make friends, just not only with your FY1 colleagues, but with all the other AHPs that are there, nursing staff, pharmacists. They will help you along the way. And know that everyone has been through FY1 that is now a core trainee, an FY2, a registrar. They've all done it and they've come through it. And again, what people have said already is just to look after yourself. They've found that what medical school doesn't prepare you for is shifts, doing night shifts, doing late shifts, and trying to work on not sleeping as well. So try and look after yourself. They've said it's been important this year to exercise and socialise outdoors, which they've all enjoyed, to learn to sleep well and get into a pattern. The first night's always the hardest night, they've said, because you think you've got a day off, but you haven't really, because you've got to rest because you're going on to night shift. They've mentioned that there have been tough times. The one that came across the most was the first time you see someone who's dying, or first time you tell a family that their relative's dying. So these are all first experiences, but again, what everyone said before is just to be kind, and remember, if you're not sure of something, you're allowed to say, I don't know the answer, but let me go and find out and I'll come back to you. And remember that there's lots of people supporting you. There's a huge network of people out there that Joe's mentioned, Caroline's mentioned, Lindsay's mentioned. They're all there to support you in your year, and they're all invested in looking after you. The other advice is it does get easier. So the first week's the hardest week, and then it gets easier, and then each block it starts again, but it does get easier. And it's okay to feel anxious, it's okay to feel stressed, it's okay to feel upset, but just come and find someone and talk it through. Lastly, it's hard work, it's exhausting, but it's worthwhile, is what someone said. I think that's me, and I'm going to hand over to Victoria on Teams, who's going to tell you more practical aspects. She's also the youngest speaker today, I think.
Yeah. You hear me okay?
Yes.
Great, I'll just bring the slides up. Can you see my slides okay here? Yeah.
Yeah.
Okay, great. So, hi everyone, I'm Victoria. I'm an FY2, just finishing FY2 in my last week now. And I've just been asked to give you some top tips for foundation training from my point of view and the point of view of my colleagues who are just finishing. Apologies in advance if some of this is a repeat of what you've been told this morning. I've not seen those presentations. And I'll be happy for any questions you want at the end, no matter how silly you think they sound, because I'm sure many other people will be thinking the same thing. So I'm just going to cover the basic sort of normal FY1 jobs, some chat about portfolio, which I know there has been a talk on earlier, some useful resources for you all to have, a few top tips, just a brief bit about some of the things you can do after foundation training, and lastly I'll mention the West of Scotland Foundation Forum, for which I'm one of the co-chairs this year, and we can let you know about how you could get if you're interested. So in terms of FY1 jobs, some of you will maybe already know, but there's some differences between your normal daily in-hours jobs between sort of 9 and 5 and those out of hours. In hours, you'll mainly be doing ward round jobs, so whether the consultant registrar or your FY2 IMT colleagues or surgical core trainee colleagues have done the ward round, you'll be asked to do a lot of jobs for them. A big one is discharge letters, which is a bugbear of many, but it's an important thing to do, and it's an important thing to do well. And it's something you will get a lot quicker at as you go. Clerking in new admissions and making referrals to other specialties. Bloods and cannulas are common, depends where you work. Some places, like I was in Crosshouse in FY1, and they had clinical support workers and ANPs who would circle the wards doing some of these for you on top of the phlebotomist, but other places don't have this, so where you are will vary with how many you end up doing. And requested investigations is another common one. For investigation requests, the big advice would be make sure you put a question at the end of your request. So if you're requesting a scan, the radiographer or radiologist needs to know why you've requested that, so they know what to look for. Out of hours, it's mainly acute tasks. Again, depends where you work, whether there'll be any routine stuff you have to do. But after 5, it's usually things like reviewing unwell patients or falls reviews, for example, doing prescriptions for patients and chasing outstanding results from the daytime. My advice for those of you handing over to your colleagues about chasing results and those getting the handover is make sure that you get information about what to do with the result. So you'll learn quickly if you aren't given that information, that if someone just asks you to chase a set of bloods without any clinical information, it's very difficult then when the result comes back and something's not quite right to know whether anything's needing done. So it's really useful if you're handing over to your colleagues to say, can you chase this? If the potassium has gone up from yesterday, you'd be wanting to treat that or change some medications. Just give a bit of a plan. And if you're the one getting that handover, just ask your colleague what it is that they want done. So IDLs, bane of many FY doctors' lives, but unfortunately very common and very important. My advice would be keep it clear and concise, and just think, if you were the GP, what would you need to know about this patient who's now coming out from hospital? Or alternatively, if this patient was to be readmitted in a week's time and you were clerking them in, what would be useful to know from their previous admission? So I've done sort of a rough example of how a lot of IDLs are done on the right-hand side. It obviously varies between people and between wards and specialties, but in general it's useful to start with a little bit for GP actions and then to list any things that the GP needs to do. This means that they can really quickly see if there's a blood test they need to do in a few weeks or change any medications. It just keeps it from things getting missed. It's useful to give a brief summary of either their presenting symptoms or what procedure they came in for, and any investigations they had while they were in, their eventual diagnosis, what management they had, be that medical, surgical, etc., and then any follow-up that you have planned. It's also useful when you sign your name to say your specialty and your ward, and it means that if the GP has questions, they know where they can call to get further information. If you've got patients who've been in for longer or have had a very complex clinical course, the discharge letter will vary for this. But my key advice would be try and keep it as concise and organised as possible. The GP doesn't need lots of big fluffy prose paragraphs to get the point. And if you're having a quiet day earlier in the week and you know someone's going home from your ward the next day, something you can do is prep the IDLs in advance so that you can leave it as a draft, you can save it as a draft on the system, and then that means it's just quicker later in the week, or for your colleagues if they're having a busy day when they're on to do them. Clerking patients is another common one, particularly in surgery. So some specialties will have clerking booklets, which is useful because it gives you all the bits you need to fill in, and that keeps you right. If you're doing it not from a set pro forma, clerking is just the basic history you've basically taken at university from every patient you've done a comm skills with. So it's just all the parts of the history, what they've come in for. Examine them. You would generally do a sort of rough top to toe. You can focus more on the area if they've come in with, a cough. You would put more focus on that. But generally a top-to-toe examination so you don't miss things. You would figure out any initial bloods or investigations they have, so for example in surgery, whether they would need any group and saves if they're coming in for a procedure. You'll do a VTE risk assessment and make sure they're prescribed low molecular weight heparin if it's necessary. Wards normally have, or the pro forma booklets would normally have a checklist for the VTE risk assessment that you'd be able just to go through. And then you'll prescribe their routine medications, whether that's on paper cardex, which are now all being phased out, or HIPMA, the online prescribing system. Another thing you'll have to do frequently is discuss patients with your seniors or with other specialties such as radiology if you're asking for a scan. The main advice for this is to be organised and know the patient's background and know why you're calling, know what you're asking. And you'll have heard of the SBAR format, and that's useful to use just to structure. Calling seniors in particular or other specialties can be really daunting when you first start. I remember that made me nervous initially, so I found it useful, at least in the first instance, to just write myself out some little notes of the key points that I was wanting to get across to keep my discussion organised, and that can be helpful. So the main things to have at hand that you'll pretty much always be asked for will be the patient name and CAI, the reason that they've come in, their clinical course so far, so know their recent blood results, know what previous investigations and imaging they've had, and their medications that they're on. There'll be other stuff depending on what specifically you're asking about, but that's generally useful to always know. And importantly, record the name, the full name, the grade, and the specialty of the person you speak to in the patient notes, just to make sure there's a clear evidence trail there for whoever reads them next. Patient reviews are a very common one and also quite daunting initially. The picture there is not for you to read, that is just to highlight something I used a lot when I first started was the website OSCE Stop, which gives you all the usual OSCE examinations and whatnot. They also have a page, for example this one, which is about common things you'd be asked to review, and so falls was one I found was quite common on medical wards in adult medicine. So I initially didn't really know what I should be doing for that, and this just took me through step by step what I should be making sure. So these are sort of some of the main things you'll be asked to review acutely, and just having something like this to walk you through it can help. But at the end of the day, it all comes down to, if it's an unwell patient, just an A to E assessment, which I'm sure you'll be fed up hearing about and will have been drilled into you all throughout university, but it really does just come back to that. Once you've reviewed, if you don't feel confident initiating investigations or treatment yourself, or you just need a bit of advice, always just escalate. There will always be a senior you can speak to, and especially at the start, they will absolutely understand that even if it seems simple, if you just need some reassurance, just make sure you run it past someone, that's what they're there for. Prescribing is another one that can be make you a bit nervous initially. For prescribing drugs and medications, make sure you have the BNF app and just be very cautious about prescribing things from memory. Some of the common things like paracetamol, obviously you'll know the doses, but just be very cautious, and if in doubt at all, check the BNF again. And remember, there's different indications for medications that can alter the dose. Check the contraindications and cautions in the BNF, particularly in adult medicine, and there's a lot of comorbidities. Just make sure there's nothing there saying that they shouldn't have the medication. And check if the patient has an AKI or deranged liver function, just check for that too. And same goes for things like if pregnant people are admitted to the wards or they have low weight, then just make sure you take that into account. For example, one that is often you don't think about just because it's paracetamol and it's so common and it's all the time, is if a patient's under 50 kilos, they get only the 500 grams, not the gram, and that's something that can easily be missed just because it is such a common drug to prescribe. There's also on the BNF app, there's a medication interactions checker where you can enter all the different drugs the patient's on, and it will bring up all the interactions and give you details about it, so that's really useful. Also, if the ward you're going to has HEPMA, which is the electronic prescribing. That will automatically highlight any interactions when you prescribe as you do it. The other thing for prescribing is fluids, and I remember well from university that it all seemed very much like voodoo, how much people were given at the time, and it took me a while to get my head around what to give. On basic terms, there's the different reasons you give fluids. So maintenance fluids in general, as a general rule, will be 2.5 litres a day for guys and 2 litres for women. The type of fluid varies depending on which hospital you're in. Common ones are things like Hartman's or Plasmolite, but just see what your hospital uses. That'll be, you can find it out this week while you're shadowing. And also take into account things like heart failure or elderly frail people, or any other reason that would alter what fluids a patient should be taking in. You can then just divide those maximums by 24 hours, and that'll give you the rate at which you would prescribe fluids for maintenance. If you think they're dehydrated clinically, you can then add replacement fluids on top of your maintenance fluids. So you would give them their normal maintenance plus however much you think they're dehydrated. And then there's obviously resuscitation fluids, which how fast and how much you give would vary based on their clinical condition. And you can give fluid challenges if you think that's indicated. But again, if you're ever concerned about this or you don't know, just ask someone and they'll be happy to help. And like I mentioned, just be careful with certain prescribing certain fluids in certain situations. Another one to consider would be electrolytes can only go to maximum rate. So for example, if you're giving stat bags of fluid, a safe one to give is normal saline in most patients because there's no potassium in it, and you can't give potassium above a certain rate on the wards. So just something else to be cautious about. And difficulties with night shifts were already mentioned by Dr. Uman, so this was just a couple of points that myself and some others had come up with. So on night shifts it will generally be acute tasks rather than routine ones, so you shouldn't be doing discharge letters and things. And despite being busy with those acute things, it can often be interesting with new presentations or unwell patients, and not doing all the IDLs is also very nice. On nights you've got a smaller team of medics on shift, and that can be really nice to have a closer team working overnight. So that's definitely a benefit. They're often hardest for people between sort of the 3 and 6 in the morning when people start to flag, so it's just something to be aware of. And if you do manage to get a break around about that time, it's useful to try and find somewhere to even try and get just a half-hour cat nap, and it can be really beneficial. Everyone thinks coffee is the solution. It's great at the start of your shift, but just be cautious towards the end of the shift, because when you drink it at 8 in the morning and then you get home and then you can't sleep all day and then you're really tired on the next shift, that's not so good. And make sure you bring plenty to eat. Your body goes crazy overnight if you're staying up, and you won't necessarily know how much or little you're going to eat, so make sure you bring enough. If you're working, for example, in the Queen Elizabeth, there is the night cafe that's open between 10 PM and 3 AM, which do food including pizzas and toasties and things, and coffee. So that's useful, but it's not, I don't know if it's the case other places if they have night cafes. And then obviously just be very careful driving home, particularly those of you who are out in places like Ayrshire or Lanakshire and Forth Valley and living in Glasgow, so just be careful. Most hospitals should have accommodation that's available for you if you feel too tired to drive after a shift, but that's just something to clarify with your hospital at your induction there. So portfolio is something a lot of people don't like keeping up to date with, but it's not too much of a taxing job if you don't leave it all to the last minute. I know the portfolio is changing this year, and I know you've had a chat already, so this was more just a couple of points from someone who's just been through it. So your supervised learning events, things like mini KEXs and CVDs, I know that there's a very low minimum this time, but they're very useful learning opportunities. It's a good way to get feedback from seniors on what you're doing, but also it's really good evidence to show curriculum coverage and to link to your curriculum to prove you've done it. So I would advise doing more than the minimum just if you can, and seeking out opportunities on shifts. Your seniors will all still be doing things like mini kexies and CVDs, so they're well aware of what's involved, so should be happy to do it with you. Reflections were something a lot of people struggled with to start with, just knowing what exactly to write for reflection. It doesn't have to be a big life-changing event, it can be little things where you've learned something, but something that can be useful that was suggested to me at the time was if you look up reflective cycles on Google, they'll just give you a starting point of a structure to do it. So there's ones like the Gibbs reflective cycle that just talks you through the stages of writing one, and that can be useful in the first instance. Your core procedures that you have to do are things like venipuncture and doing bloods, etc. Some of these are really simple to get signed off, like the ones I mentioned. Other ones are harder, depending particularly on where you are. Things like doing peak flow or airway manoeuvres. So look through them, see what you need to do, and figure out early opportunities to get these done. You can actually get most of them signed off in the first block, which is what a lot of people manage to do, and then you don't need to think about them anymore, which is good. And tabs, which are your team assessment of behaviour, you need people to feedback on your performance and how you are as a member of the team. Our advice, I'm sure anyone who's currently working will give you, is send out more than you need, because people will not fill them in and you'll be chasing them. So a good time to send them out is any time from about halfway through the block, once you've sort of got to know the people you're working with. If you start sending them out then, it's useful. Don't send them out at the end, because you won't get them back in time. It can take some people a good 2 months to fill them in for you. And that's really goes for all tickets you're sending out. Send them out early, and you will have to send reminders to get people to fill in your tickets, unfortunately. But just remember that when you then become the senior, filling them in for people. Teaching is recorded on your portfolio. It's been a lot of virtual teaching in the last year, like was mentioned, because of COVID, which is great and very accessible. However, some people have found issues with firstly finding space to do it, but also if you're on the ward and tuned into teaching, you will often just get asked by the nursing staff or other people to do stuff because you're there and because you're visible. So if possible, and there's space for you to go, it's easiest if you are able to get off the ward for your teaching. And you can let the nursing staff and let your seniors know you'll be away. You can tell them that to keep a list of routine stuff, and you'll get it when you get back, that you don't need to be paged about it. And if it's protected teaching time, it's usually that the on-call person is the only one who should be getting paged during teaching time. But try and be quite strict with yourself about attending teaching, because it's very easy to not attend, and soon you'll realise you're missing all the opportunities, but also running out of time to make up your hours. There's also learning and foundation training and e-learning for health modules, which are on you can access through the virtual learning tab on your Curas portfolio. These are good, they're short, they're generally about 20 minutes on average. They're good ways to make up teaching hours and cover topics that aren't necessarily being covered that you think you could do with. And with them and with everything else you go to, just record everything on your portfolio as you go. You need to link things to your curriculum, and it's very hard at the end of the year because you forget what the content of everything was to then figure out where it links to. So just do it as you go. Taster weeks are something else that you can do towards the end of F1, start of F2. They're really good opportunity to get to experience something different, which is particularly good for you guys, as I know you have your F2 jobs already allocated, so you'll know if there's other things you want to try. But just try and organise them early, because you need to be able to get away from your off your ward. Your rota needs to have slack in it to allow you to go away for a week. So just get in early and organise them. And for ARP-P, which I'm sure you've already heard about, just to say there is good guidance on the Scottish Deanery website with basically a checkbox thing of everything you need. One key thing that's come out for a lot of my colleagues this year is make sure supervisors sign off your forms. So I know of a few people who initially didn't get to pass an RCP because their supervisors from previous blocks hadn't signed off their meetings. Once that was then signed off, they were then able to pass an RCP, but it just saves you that stress at the end of the year. So if they aren't signing them off, you can email them a couple times, but have a low threshold for escalating to your programme director if you're struggling. So these are just some useful apps that I would recommend everyone gets, depending on where you're working. The BNF app, as I mentioned, and you can change it into the children's BNF if you're working in paediatrics. Induction has all the phone numbers for the hospital and is very useful, particularly because switchboard can sometimes take a long time to answer calls. GDC Medicines app is a really good one for our guidelines in treating many conditions, so very useful out of hours in particular. For anyone working in paediatric surgery this year or paediatrics next year, if you look up the GDC Paediatric Guidelines app, you can also get it online as a website, but that has a lot of information on there about conditions in children, so I would recommend that one. And the iResus app just has all the resus algorithms and is very useful if you're having a mind blank, so that's a very useful one to have. Some resources, there are many, many more. These are just some that have been useful. So you've got the internet and hospital guidelines. The only thing is the internet can sometimes be a bit of a rabbit hole to try and navigate. But you've also got nice clinical knowledge summaries, which are useful if you're not really sure about a condition. As I mentioned, OSCE Stop and DT Medics, which I'm sure many of you have used already in uni as guides for OSCE preparation, but if there's things that you have forgotten how to do or you just want a refresher on, particularly at the start of FY1, that's actually really useful to look back up. A lot of people aren't very confident with dermatology, and one thing you'll get asked to review in the words is rashes. So DermNet, the DermNet New Zealand, is really useful for information on that. And then there's the standards like your Oxford Handbook and BMJ Best Practice, and they're all just useful just to give you that sort of little bit of information if you're not sure. And your seniors will be able to give you a lot more resources if you're looking for them. So the key tips on how to survive foundation would be, as has been mentioned, ask for help, whether it's about a clinical thing or a personal matter, just ask for help. You can ask from your fellow FY1 colleagues, and make sure you support each other because you're a really good support network, and you're all going through the same thing at the same time. But you can also, you've got your seniors, your supervisor and your programme director, so there's lots of people to ask for help, whatever it's about, so don't suffer regardless. Make sure you take your breaks. Easier said than done, we still struggle now, but try your hardest to take your breaks. Again, tell the nurses you're going off the ward. If it's routine stuff, just keep a note, you'll get it when you get back. And at the end of your shift, hand over your jobs. You can fall into the trap of feeling guilty about handing over jobs and therefore staying hours late. That's not beneficial for anyone, and you'll just get worn out, and you need to be able to hand over, turn off and go home. So make sure you hand over, but as I mentioned earlier, give clear stories, clinical stories when you're handing over, so that the person you're handing over to knows what to do with the information. Have an organised jobs list, really, really important. You'll find your own way of doing it, but other people and seniors can give you advice on how they do it if it helps. One thing that's useful is if it's really, really busy and your jobs list has turned into several pages and half of it's completed and half's not and it's all a mess, just pause to collect your thoughts, but also you can rewrite your jobs list, and it does take 5-10 minutes, and it feels like on a busy day that you really don't have time to do that, but actually just taking that 10 minutes and reorganising all of that can actually make you more efficient, so I would really advise doing that. And make sure that when you document in notes, make sure it's clear, particularly your handwriting, concise. Again, unless it's complex discussions or things in general, you can go for not prose and just short bullet point sentences. Keep up to date with your portfolio. I know it's easier said than done, we all know that, and we still don't do it often, but I would definitely advise trying to keep up as you go. And again, there's a lot of helpful advice and guidance on the Scotland Deanery website. There's a section for trainees and there's a section about foundation. So if you've got questions, that's a good place to go. Just about options after foundation. So I know it's 2 years away, but it's something some people might start to think about. And this is basically to say you don't need to know what you want to do yet. You don't even need to know what you want to do by the end of foundation. There are so many different options for you after foundation, including going into training or doing a single year of training or doing fellow jobs in multiple different areas, going abroad, doing locoming, or just doing something non-medical for a while. But it's not you must know what you want to do by the end of foundation. Definitely not the case, and a lot of people don't, and people do stress about that, but it's not the case. So now I just want to chat briefly about the West of Scotland Foundation Forum. So this is a group of trainee representatives from across the west of Scotland. I am one of the co-chairs this year, finishing up now, and we're handing over to our new co-chairs tomorrow night actually. The goal is to have an FY1 and an FY2 rep from every hospital across the west of Scotland, and sometimes more depending on the size of the hospital, which has worked really well for the last year. Reps are there to gather feedback from other trainees, and we have a Teams meeting every sort of 5 to 6 weeks, so it's dead easy to attend because it's via Teams. And at that we discuss any feedback. It can be about anything job related. This year we've covered all sorts of things such as inductions, issues with rotas, issues with rota monitoring, even things like having the space to go and sleep overnight on a night shift. We can cover anything that's job related, so it's useful to bring that. The forum is not just standalone. We liaise with the foundation programme directors via Dr. Uman, who attends our meetings, with Dr. Whitten as well, and the chairs attend the Foundation Training Committee, which is the meeting of the West of Scotland Foundation Programme Directors. We also have the co-chairs and the lead F1 reps will attend the Scottish Foundation Trainees Forum, which is a handful of reps from each of the 4 regions that get together every couple of months, with staff from the deanery attending, and again that allows us to feedback that way. And then designated reps from that forum will then attend the Scottish Foundation Programme Board, which is the overall Scottish Deanery meeting, which happens, I think it's 3 times a year. So one of the big things we're currently working to improve is rota provision. I'm just bringing this up as I'm working on this with Dr. Whitten, and we will be sending out a survey a few weeks into each block to see when you got your rota and if you got your annual leave and things like that. This is an ongoing re-audit process, and we are going to work to try and improve the time in advance with which you get your rota. So if you're able to fill out these surveys when they come out, it will help us keep an eye on where is struggling with providing rotas and help us identify the issues that the rota teams have with getting these out, to try and make it better for you all. So that will come out in a few weeks, and just if you can, it only takes a minute just to fill that in. So if anyone wants to get involved in the forum, as I mentioned, we need at least 1 rep per hospital from FY1. The role is listed there, and as I mentioned, it's to identify feedback from your colleagues, attend the meetings and raise issues, make sure that other foundation doctors in your hospital know that you're the rep and can contact you, give them the feedback from the things that we solve at the meetings, help us find these solutions, and also if there's things that you're wanting to look at fixing, such as, for example, things like rotas, there is the opportunity for doing these sort of QI projects that you come up with support from the forum, because it gives you a network of people to help with this. To apply for this, there's our email at the top of the screen. Can you just submit a short paragraph? It doesn't need to be long at all, just saying why you would like to be a rep and what you can bring to it. The alternative is that we need 2 lead FY1 reps. So these, as I mentioned before, you'll do the forum rep role, but you'll also attend the Scottish Foundation Trainee Forum meetings. every couple of months. For that, again, just a short personal statement, no more than 300 words, it can be less than that, just saying why you think you would be good at this role and what you'll bring to it. So that's our email at the top of the screen there. We are going to be getting a new email soon, which will be at nhs.scotland hopefully, but we'll advertise that when that comes out. So if you would like to get involved, just email into there. So that's all I have to say. That's my email for any questions, no matter how silly you think they are. I'm happy to be contacted, and our forum email, which I also man at the moment, so you can let us know.
Thank you, Victoria. That was brilliant. Any questions from anyone? Any questions on the no chat? Maybe Michael's gone. Victoria, that was brilliant, and just thanks to you, Fiona and Tom, for leading the Foundation Trainee Forum this year.
Thank you.
I don't know if we've got any questions, actually. No. No. Thank you, Victoria. Bye. And then I'm just going to introduce Ian Reeves, who's going to do a talk on civility, and it's a recorded talk, so I think we'll be ready to go soon. He is also an FPD and works in the Queen Elizabeth as a geriatrician, and you will see him across the wards when he does liaison. So I will just hand over, I think.
Good morning, my name is Ian Reeves. I'm one of the medicine of the elderly consultants at the Queen Elizabeth Hospital in Glasgow, and I'm also one of the Foundation Programme Directors. So I'd like to say hello particularly to the W31 trainees. I look forward to meeting you shortly. I hope you have a great start to your foundation training, and I look forward to working with all of you throughout your training over the next 2 years, regardless of which programme you're in. If you're ever in QEOH, you can always stop and say hi. This slide set was generated by Lisa Black, one of the emergency med consultants from Crosshouse Hospital. I have amended it slightly, so I'd like to make sure you know that all the good bits are hers, and anything that doesn't look quite so good is mine, because she's done this talk very successfully before. I'm also very aware that it's just approaching lunchtime. You've had a morning of talks, and this the day before. My intuition tells me that it's just about to stop raining, and that you're looking forward to lunchtime. That may be something to do with my very good weather app that I also use. So I'm going to try and skip through this. I was also involved in some of the preparation for practice work with Glasgow University, and I know from the feedback that you've had quite a lot of this sort of professionalism and other teaching as well during your training already. So if some of this is repetitive, I apologise. I've also taken a slightly different slant on it towards the end and just asked a couple of questions about the whole process and the term civility saves lives and what it actually means as well. Fairly obvious when you look at something as successful as the All Blacks from the outside. They also have what's called a no asshole rule, where they call out any behaviour that they think is not productive to the rest of the team. I'm a half Welshman, so rugby gets conflicted in our household, particularly during the Six Nations. But I'm also a massive admirer of how the All Blacks do things. There's a fantastic book, if anyone's interested in teamwork and how they work, called Legacy, which is a really good read. And it describes particularly how after winning a championship, one of the teams was celebrating, but after they celebrated, they made sure and they tidied up the changing room, they cleared out the bins, they sorted everything out, they let's call it sweep the sheds. They do everything else they need to respect everyone else that helps them as well, which I think is a lesson for a lot of us in all our lives as well. Do good teams matter? Well, other members of my family are Arsenal fans, which is a pretty lean time for them at the moment. Or if you're in Scotland, that's probably the same for Celtic fans. I have twin boys actually, one who supports Rangers and one who supports Celtic. So I always have one who's happy and always one who's very sad. So yeah, I know the importance of teamwork as well in everyday life as well. Teams also need really good leaders. Richie McCaw is the All Blacks captain. He's also written a fantastic autobiography, and he's incredibly self-deprecating for a man who is the most successful rugby player of all time and truly one of the great sporting legends. It's amazing how humble he is in writing what he does and how much he always just seeks to improve and learn on what he does. And every day he just writes start again as his new mantra. He has no airs or graces whatsoever. He even turned down a knighthood so he could accept a supposedly lesser reward, but more pertinent to his heart in New Zealand as well. So, as you can probably tell, a bit of an All Blacks fan. Why do good teams matter? Well, for healthcare, it's become more evident that there is variation in performance. People have looked at this, what makes it work well in some places and not so well in others. And when people self-describe themselves as a team, then they have better outcomes such as reduced mortality, reduced complaints, more staff satisfaction, and everyone just feels better. It feels better, it works better, it looks better. And I'm sure if you've all had that feeling, you can walk onto a ward, even as a student, you can walk on and feel whether somewhere feels tense or whether it feels friendly. I've also had that sitting in a clinic sometime. You just observe quietly while sitting in a clinic the manner of how people are and how they interact with colleagues and how they move around. So all these things get noticed quite subtly by all of us, including our patients as well. And it gets noticed in the figures. So we all strive that we think we should have teamwork. And what is incivility? Well, incivility, if we take sort of sidestep from teamwork and we end up in this place, what is it? So it's called rude or unacceptable speech or behaviour. I've got another example towards the end that I think is slightly more snappy. And it's anything that's interpreted by that third party as that, even if the originator of it didn't mean it. So what happens when someone's rude? There's a tendency before, I think we've just ignored it, we'd have blamed ourselves and said I'm being oversensitive, or it's just my nature to be how we are, or if we accept it from other people, some people have made a career out of a slightly effective rudeness, such as Gordon Ramsay. It seems to be somehow just a character trait for some people that seems to be allowed to behave, and we particularly see it amongst leaders and even some of our politicians as well. What happens when people are rude? Well, this new phrase I'm sure you've all heard it called cognitive bandwidth or cognitive load. Starts to affect how much we can do at one time, and it starts to distract us. If you start to worrying about how something has affected you, then that may also affect other aspects of what you're trying to do as well. Now, there's some research which, if you look at the Civility Saves Lives website, they have an evidence tab. And as part of this, I went to refresh that, and actually it's not changed very much, which is something I'll maybe mention a bit later on as well. But talking about the reduction in cognitive ability, that if a negative event happens to you, how good are you in terms of doing something? And this was tested from a sort of observer of a meeting, constantly saying to people, I don't think this is very good, you wouldn't get a job in my country, as an external observer, and showing how people's cognitive ability declined as a result. And I'm sure we'd all recognise that. If you've just done an exam situation, if I made you all sit in a room for half an hour before and someone tell you, remind you of all the mistakes you've made, remind you how negative you'd been in some of your schools, you wouldn't do that. When you want to go into an exam, you want to be good, you want to be remembering all the good things you can do. So we know that individually that has an effect on us as well. And what happens has been well measured with some of this as well, and I won't go through all of these for the sake of time, but people worry about it and it affects them. So it reduces how well they can work, and ultimately it causes people to experience dissatisfaction with their work, such that they either leave, or as I'm sure you've talked about in other talks as well, issues such as burnout start to prevail in people's lives. Not only is the person who's the recipient of it that's affected, even the observers of rudeness or antisocial behaviour can be affected, and they can make errors as well, according to this research on Civility Saves Lives, and I'll say a little bit about that at the end. And for other people as well, I'll say it's not just our interactions as professionals, this is well noticed by others. My brother has a rare neurological disorder that required him to go to hospital and receive immunoglobulin for a while, and because he was so interesting, he used to get used by quite a lot of medical students, and he used to notice how the registrars or the trainees were being treated by different people and how that interaction happened, and became quite sensitive to it, and also very aware that those people were very vulnerable. He actually learnt so much about his condition that when he felt they were being unfair on the students, he would turn the tables on the registrars and sort of ask them difficult questions about his condition, which he knew full well they couldn't answer. Slightly difficult behaviour, but it does show that even the recipients watching it feel aggrieved and feel that there is something wrong with the system, and they become resentful of that. So how do you always make sure you come back to teamwork? This is the main study that's been quoted quite a lot. There's a risk in areas that teams cannot perform well in the presence of rudeness or incivility, and they defined it as dismissive, rude, or aggressive behaviour, RDA behaviours. And I think that's probably a nice way to put it, but you remember RDA, if you remember nothing else from this, remember RDA, rude, dismissive, or aggressive. And if you ever have a moment in your future career where you're not sure whether something is, say, was that rude, was that dismissive, or was that aggressive? And then recognise that and be able to call it. And I think we should be able to use it, and if we can normalise this behaviour as an RDA event, then I think that helps make it less confrontational than saying something is either bullying or uncivil. I think using RDA is a good way to get around that as well. So I hope we can manage that. So onto this evidence that everyone talks about. This is an infographic again from Civility Saves Lives. They took a neonatal setting. It's quite niche in some ways, and it was a neonatal setting to start off with, and then general surgical setting as well. They role play quite carefully, and the study is very well done in terms of how well it was scripted. And although they described the surgeon as rude, it wasn't actually rude, it was just more unhelpful. It wasn't throwing plates level rude. It was just particularly unhelpful and more passive. And they showed a change in the performance of the anaesthetists when the videos were watched blinded by observers later. So the methodology of it was pretty good, although it was a very small study. I actually went back and had a look at this study, and because I was looking for any new information that appeared, and there isn't, so I had a look at this study in a bit more detail. I'm going to show you on the graph here. These are the scores that they had for the anaesthetists on what settings they measured: vigilance, decision-making, communication, teamwork, technical performance, non-technical performance. And the blue parts are the control group, and the sort of pinker parts are the intervention group. And what you can see is the sort of overlap between things and which ones were more affected. So non-technical performance, technical performance were the worst affected. But you can see also how much overlap there was. So although the score overall was different, there's a long tail on these, and some people seem to have much more deterioration in their performance, and other people had very little impairment of their performance. So it's by no means a binary distribution, and I think there's a lot more work that people can do in this to try and work out what it is. And I hate the word snowflake or lack of resilience, but there does seem to be a difference in performance. It's not universally the same, despite being very random. And if these were patients, we would want to know more about these. So I think there's a lot more work that we could do, and if anyone's interested in medical education research, I think this would be a good place to go. This study is now a couple of years published, and it's only published in the Journal of Quality and Safety in the BMJ. It didn't achieve a really high impact, and that's also made me wonder why it hasn't been repeated. We know from psychology research in general that lots of psychological research doesn't get replicated, and that's a real problem. There are lots of famous psychology studies which have never really been replicated, and when people do, even a couple of decades later, try and reproduce them, they often find the effect isn't as big as it was before. And I think this would be really interesting to even just to repeat this study in a different group of people to see whether we get the same result. I think is a valid research question, because there's a small numbers in one country, in one particular area of practice. And there are very specific circumstances, and it may not be as large in other situations. And I don't think we can use that overall example of saying the cognitive effect of any bullying is if I haven't slept. I think that's a slight leap from Civility Saves Lives. I just worry slightly that the Civility Saves Lives campaign, whilst it has lots of good work in it, shouldn't overemphasize and shouldn't become hyperbolic about how great the effect is, because there may be differences as well. And I think there's a lot more research that we need. So yes, there's one interesting study. Yes, it looks like there's an effect, and we need to be cautious about it. But don't let's overegg that research, because if it turns out that it's just like curate's egg, then we haven't got anything else. So let's build it all carefully. How do people become incivil? I think you've learned quite a lot about burnout and resilience as well. There's no doubt that when we're tired, hungry, emotional, other things going on in our lives, it's much harder to be kind all the time, and that creates what's called an incivil clinician. And I think there are all moments where we all recognise variations in our performance. There are all times when we can recognise when we're working well and we're kind, and times when we don't. And the trick, I suppose, is to make sure that we have good enough support networks that call us and help us when we're not doing as well, and the ability to be able to recognise that ourselves as well. So one of the incivility certified headlines is talking about not overlooking incivility, and we've set poor outcomes for our patients, which is, the standard you walk past today is the standard you will expect to receive tomorrow with a patient, and that's true. If you walk past and see someone in distress, then it's the same for our teams. We're condoning future generations to the same effects that we have, and things are a lot better between generations compared with some of us who are older with trainees as well, but that doesn't mean it can't get better as well. I'm still desperate for it to improve, even though its magnitude's better than when some of us train. So what can you do? Monitor your own rudeness, be polite and kind, and there are lots of initiatives at work that I think have really helped us, making sure we take time out to recognise each other as well. And I say call it out, use the RDA, rude, dismissive or aggressive, and look after the people that demonstrate those good behaviours. Let's reward them. Let's make sure we notice. Calling someone out, I stopped someone the other day and said I noticed how much time we took doing that with that student nurse, and I thought that was really good, and I thought that was really kind. And we had some really positive feedback from the student nurses afterwards as well, just from their whole ward experience. So try and remember that all the time as well. These are the references that we've talked about, and they're all on the Civility Saves Lives website, which I say has had a sort of peak from a couple of years ago. And I think if this movement wants to continue, it's going to need to generate some more research as well to keep us informed about what's really happening. So thank you very much for your attention, and particularly as I know it's been a long morning for you, I hope you enjoy your lunch break, and that I look forward to seeing you in Foundation. Hopefully we can monitor some questions via the chat box if there are as well, even though I can't do this live at the same time. Okay, thank you very much for your attention.
Okay, thank you very much, Ian. That was very, very helpful. So that just about wraps it up for us. I've had one question coming through about taking time out after FY1. So if you go onto the Scotland Deanery website, you'll find all the information on this. If it's something you're interested in general, there needs to be a good reason for it, and you need to apply to do so. But if you're a person who wants to take time out after FY1, speak to your Foundation Programme Director, look at the Scottish Foundation School website and apply for it formally, and the application would go through your FPD, through myself, and then through the Foundation Leads in Scotland. And the time scale in terms of coming back would be measured in blocks probably. So you could, it's 4 months, 8 months, or a year, maximum time a year. Okay. Do we have any other questions? Have we received any questions through from the top? No. Okay, no. Lovely. Well, listen, best of luck to everybody. Enjoy. And remember, we're all here to help you. Okay, thank you very much. So I'm come back on just to say my sincere thank you to the IT guys who've made this all possible at the Royal College, and to Michael McCrossan and to Lindsay Donson and the team for setting it all up for us, and also, of course, to my fantastic speakers. So thank you very much, everybody.